Thank you, Kenneth, for the introduction. I decided sitting down there that there would be equality. I would know that there is equality in the workplace for women when they had podiums that went up and down, right? So that thankfully, I thought the computer was here, so I thought you weren't going to be able to see me over the computer, but now I understand it was Ed's computer, so you'll be able to see me a little better, I think. All right, we are going to talk about magnesium in obstetrics today and the implications it has for us, the anesthesia providers. I don't have any disclosures to make relative to this topic. So here's the long version of the objectives, which is in your syllabus. The short version is we're going to talk about two major topics today. Indications for magnesium therapy in the pregnant patient, which is mostly in the purview of our obstetric colleagues, but we are going to end up taking care of these patients, so we need to know about them. And then we'll finish up with interactions of magnesium with what we do as anesthesia providers. So we're going to start with cerebral palsy prophylaxis. This is a relatively new indication for the use of magnesium in the obstetric patient. So I just want to take a poll of the audience and see with the raising of the hands, how many people in the audience have a protocol in their institution for using magnesium for this indication? So prophylaxis against cerebral palsy in the preterm infants. So about a third, would you say? Okay. Third to a half, we'll say. So it's been a question that's been around for a while. There have been a number of studies out there that were actually fairly inconsistent. In the last decade, there's been 3 or 4 major randomized controlled trials comparing magnesium therapy to placebo in women who are at risk of imminent preterm birth. This is the most recent study. It was published in 2008 by the Maternal Fetal Medicine Units Network. They randomized over 2,000 mother-infant dyads to magnesium versus control. The inclusion criteria were women, again, who were at imminent risk for preterm delivery between 24 and 31 completed weeks of gestation. Patients were randomized to magnesium, 6-gram bolus with a 2-gram per hour infusion versus placebo. And the primary outcome was a composite outcome of stillbirth, infant death by 1 year, or moderate to severe cerebral palsy beyond 2 years of age. What they found was that there was no difference between the two groups in the primary composite outcome, but there was a significantly lower risk of moderate to severe cerebral palsy in the infants whose mothers had received magnesium therapy before delivery. So 1.9% in this group of patients compared to almost twice as much in the women who received control, no magnesium. The risk ratio was 0.55. In 2009, so that's a year later, there was a Cochrane meta-analysis on this topic. The meta-analysis included 5 trials with over 6,000 babies. And I'll show you the 2 most important outcomes here. The forest plot on the top is any cerebral palsy, all right? And on the left side, let's see, where's the pointer? On the left side here, I'm pointing at my own, that doesn't make any sense. The left side favors magnesium. Now I'm pointing at Kenneth. And the right side favors control. So I think you can see that the boxes are mostly to the left side, all right? And for the top indication there, which is any cerebral palsy, the meta-analysis showed that magnesium therapy decreased the risk of any cerebral palsy in these preterm infants. And if you look at the bottom forest plot, this is moderate to severe cerebral palsy. And again, there is about a decrease in risk to about half in the infants whose mothers received magnesium immediately before delivery, or in the first 24 hours before delivery. So then a year later, ACOG and the Society of Maternal Fetal Medicine released a committee opinion, all right? And they basically said that even though none of the randomized control trials showed a difference in the primary outcome, all of these trials did show that there was a difference in the risk of moderate to severe cerebral palsy, suggesting that the use of magnesium for this indication was probably, what was the word they used? Reasonable. All right, they didn't say people had to use it, but they suggested that there is now enough evidence out there that if people want to use it, this seems to be a reasonable indication. There have been no dose-response studies, so that the group suggested that if institutions want to initiate magnesium therapy for this purpose, they should use one of the protocols for one of the large randomized trials. So this is a table that is in the practice guideline, the committee opinion of the 3 major randomized controlled trials and the dose of magnesium that was used for each one of the trials. We at Northwestern do have such a protocol, and we are all of the women, again, who are at risk for preterm delivery are receiving magnesium. Some of them obviously do go on to have preterm delivery, so we are taking care of patients who have received this magnesium bolus and have been on magnesium infusion for a while before their delivery. So the second obstetric indication is one that I think we're more familiar with, which is prophylaxis against eclampsia and the treatment of eclampsia should it occur. And just to review with you all, eclampsia occurs in 0.01 to 5.9 per 10,000 pregnancies. So that's a very wide range. Depends upon where we practice. In third world countries, the incidence is much higher than it is in the United States. Most eclampsia occurs intrapartum or within the first 48 hours postpartum. And about 1% of pre-eclamptic patients will become eclamptic. Again, that incidence depends upon where we practice and whether patients are prophylaxed against eclampsia. The differential diagnosis of eclampsia or seizures during pregnancy is quite large. All right, I think it's the same differential diagnosis of seizures that we see anyplace else. Seizure disorder, the incidence of stroke is higher in this particular patient population. Remember that pregnant patients are hypercoagulable. Hypertensive encephalopathy, again, hypertension, pre-eclamptic patients are hypertensive. Ischemia, space-occupying lesion, other metabolic causes of stroke. PRES, which is posterior reversible encephalopathy syndrome, is also associated with preeclampsia and may present with seizures. Amniotic fluid embolism may present with seizures, and then drug withdrawal. And if we just heard in the first lecture, post-dural puncture headache can be associated with seizures. So why do we use magnesium for seizure prophylaxis? This is the largest trial of magnesium versus no magnesium, called the Magpie Trial. You may have heard of it. It was published in 2002. Very large randomized controlled trial, multinational in over 33 countries. Over 10,000 women participated in this trial. Women were included if they had the diagnosis of preeclampsia by blood pressure and urine protein criteria, and they were treated with a fairly standard protocol of 4 grams of IV bolus magnesium followed by a 1 gram per hour continuous infusion for 24 hours. The primary outcome here was eclampsia, and as you can see from the bottom there, the overall result was that women who were randomized to receive magnesium, preeclamptic women who were randomized to receive magnesium had a significantly lower incidence of converting to eclampsia. It was less than half as much, all right? So I think this convinced most people around the world that magnesium therapy is the standard for preventing eclampsia. Now, the number needed to treat is quite high, right? Because I said the incidence of eclampsia in women who have preeclampsia is about 1%. And despite that, magnesium is considered now standard of care for prophylaxis against eclampsia in women who have severe preeclampsia. We'll go over that in a second. There is also a more recent meta-analysis. You can see the top trial there in the forest plot with the large blue box is the Magpie Trial. It kind of drives this meta-analysis. But again, even with the meta-analysis, you see the same result. Magnesium significantly decreases the risk of eclampsia in this patient population. So this is something new. You may have heard of it. The ACOG published a new or updated treatise on hypertension and pregnancy this last fall. So I think this was published in October, November of 2013. I think we're having a lecture tomorrow on an update in preeclampsia, so I'm sure we'll hear more about this. But I just wanted to point it out to you. You may hear your obstetric colleagues talking about it. It's got some updated information about definitions of preeclampsia, who we're calling preeclamptic, The term mild preeclampsia is supposed to not be used anymore. Again, this is not about preeclampsia, so I'm not going to go into any details. But I wanted to point out two recommendations in this publication that are relevant to us. The first one is that for women with preeclampsia undergoing cesarean delivery, the continued intraoperative administration of parenteral magnesium sulfate to prevent eclampsia is recommended. So sometimes we have been turning off the magnesium, and I'm going to talk a little bit more about the possible interaction of magnesium with our anesthetic technique in a minute. Some people turn it off. They're worried there's going to be an interaction. Some obstetricians turn it off. They're worried that it's going to increase the risk of postpartum hemorrhage. We're going to talk about that in a second too. But basically what this new recommendation is that we should not turn it off. We should be continuing the magnesium infusion during the cesarean delivery. The second recommendation that I wanted to make sure that you knew about, this is not really new, is that for women with eclampsia, all right, the administration of parenteral magnesium is recommended. And the reason I'm just reinforcing that with you is that it's likely that our obstetric colleagues will call us when the patient starts to seize. And so we will be present in these patients, and we have to know that the recommended treatment for the seizure is magnesium. We usually use other drugs in non-pregnant patients, but if we think that this is eclamptic seizure, then the gold standard here is magnesium therapy. So there's a lot of questions out there, actually. I've just told you that magnesium is the gold standard for eclampsia and prevention of eclampsia. Many more people are using it to prevent or to mitigate the chance of a baby developing cerebral palsy after preterm birth. We actually don't know the mechanism of magnesium for either one of these indications, and I'm not going to go into details today about the proposed mechanisms, but suffice it to say we don't actually know how it works. We don't know the ideal time to initiate therapy, all right, in the preeclamptic patient. We don't know the ideal loading dose or maintenance dose. There's been studies out there looking at a particular dose, but there's been no dose response studies, all right? And similarly, we don't know how long we're supposed to keep the magnesium therapy going. That being said, there's sort of some standards out there that I think most people are using. The loading dose is usually 4 to 6 grams over 20 to 30 minutes. It's usually initiated at the time that the decision for delivery is made, and it's usually continued for 24 hours postpartum. In a patient who is just undergoing a cesarean delivery, the usual recommendation is to start the magnesium 2 hours ahead of time, and as I said, keep it going during the procedure and for at least 12 hours after the delivery. As I mentioned earlier, we might become involved in the care of these patients when the patient starts to seize. They will hopefully call for the help of an anesthesia provider in this circumstance. Things we have to think about, right, are management of the airway, ABC, there's not really any difference there. And then, as I said, magnesium is the drug of choice here in the treatment of eclamptic seizures. All right, I'm not going to go into any detail on this, but I just wanted to point out to you that the definition of preeclampsia and severe preeclampsia have been refined in the last couple of months with this new publication. I'm sure we'll hear about that tomorrow, so I won't spend any time going over this right now. So the second part of the talk, we're going to talk about interactions of magnesium with the things that we as anesthesia providers do. And there's three major things that I'm going to talk about: interaction with neuromuscular blockade, effects on uterine tone, and then the interaction of calcium channel blocking agents, both with, the interaction of magnesium with calcium channel blocking agents and specifically with our anesthetic technique. So I'll remind you that magnesium is a ubiquitous drug, but it is toxic when we give it in large amounts. It's actually considered one of the high-risk medications that's used in the hospital. Therapeutic dose or therapeutic blood level is about 4 to 7. Patients start to become hyporeflexic between 7 and 10 milliequivalents per liter, so this is why hopefully our nursing colleagues are monitoring the patients by testing their reflexes, and if they start to become hyporeflexic, that's an indication to check the magnesium level. Respiratory depression between 10 and 13, altered cardiac conduction between 15 and 25, and cardiac arrest at levels higher than 25 milliequivalents per liter. This is usually a drug error when this happens. Okay, why do we need to know this as anesthesia providers? Because they're going to call us for the respiratory and the cardiac arrest. Hopefully they're going to call us to help them treat this. And as I think you all know, the treatment is calcium gluconate or calcium chloride. Remember that magnesium is eliminated by the kidneys, and so that patients who have renal dysfunction will be at increased risk of being mag toxic. All right, and renal dysfunction is common in preeclampsia. So we need to keep an eye on the renal function of our preeclamptic patients and alter the magnesium dose accordingly. All right, let's talk about the effects of magnesium on the neuromuscular junction and the interaction with neuromuscular blocking agents. Magnesium at the neuromuscular junction inhibits the release of acetylcholine. It decreases sensitivity to acetylcholine and depresses the excitability of the neuromuscular membrane, so that when we give magnesium in conjunction with the neuromuscular blocking agent, it markedly potentiates the action of the neuromuscular blocker. Here's a randomized controlled trial in which the investigators induced general anesthesia, and then they gave a bolus of magnesium. It's about 4 grams for an average-sized patient, and they gave a dose of rocuronium, pretty standard dose, 0.6 milligrams per kilo, and the primary outcome here was the return of the train of 4. So time is on the y-axis here, and the black boxes are the magnesium group, and the open boxes are the saline group, and you can see that by all train of 4 measures. So the appearance of the first twitch, when the first twitch returned to 10% to baseline, and then 25% to baseline. By all of these measures, the group that got magnesium, the duration was about a third longer than the group that got saline. There have been several case reports out there of preeclamptic women who have been receiving magnesium and then got a standard dose of neuromuscular blocking agent. Here, these 2 case reports, the patients got between 2.5 and 3 milligrams of vecuronium, and the duration of neuromuscular blockade was 3 to 5 hours. I will tell you my anecdotal experiences having given 20 milligrams of rocuronium. I thought I was being especially careful in giving a very low dose of rocuronium to a patient who had received magnesium, and she was intubated in the ICU for several hours. It was a little bit embarrassing. I didn't write a case report. But I've never given a neuromuscular blocker to someone on magnesium again. All right, second thing we want to talk about is effects on uterine tone, right? Because magnesium, I just told you, is a skeletal muscle relaxant, is also a smooth muscle relaxant. So people have been concerned that it will have a negative effect on uterine tone, and we all know that the primary mechanism for preventing hemorrhage after delivery is uterine contraction. So if we have a problem with uterine tone, are these patients at increased risk for postpartum hemorrhage? So this was looked at as a secondary outcome in the Magpie trial. This is just the meta-analysis with a couple of studies. And I think you can see that this big blue box straddles 1 right here. That means that there was no increased risk of postpartum hemorrhage in the women who were randomized to receive magnesium for their prophylactic preeclampsia for prophylaxis of eclampsia compared to the control group. So even though this is a thing that's in all of our heads, in our obstetrical colleagues' heads, it doesn't appear to be real. These women do not appear to be at increased risk of postpartum hemorrhage. So thankfully, we don't have to worry about that one. And the last thing I want to talk about is interaction with calcium channel blocking agents and then with our anesthetic agents. So this has been a question because there were anecdotal reports out there that women who received nifedipine for control of their blood pressure or for preterm labor and were also receiving magnesium had an increase in just generalized muscle weakness. They had myocardial depression and were at increased risk for circulatory collapse if we gave both of these drugs at the same time. A group in Washington a couple of years ago did a retrospective study in which they looked at all of the women that had received magnesium at their institution for the past couple of years. There were 377, and they divided the women into 3 groups: those who had also received nifedipine, those who had received other antihypertensive agents, and those who had received no antihypertensive agents. And the primary outcome was neuromuscular weakness. And as you can see from the top line of the table, there was no difference among those three groups. So the patients who had received nifedipine were not at increased risk for muscle weakness, nor were they at increased risk for hypotension. So this concern seems not to be a valid concern, and we do not have to avoid calcium channel blocking agents in this particular group of patients. All right, well, there's always been a concern, or when I trained, there was a major concern about giving spinal anesthesia to women with severe preeclampsia, and particularly giving spinal anesthesia to women with severe preeclampsia on magnesium. I was taught back in the old days that this would lead to cardiovascular collapse because preeclamptic women are volume constricted, and when we vasodilated them with our spinal anesthetic, we would cause catastrophic hypotension. People have heard of that? All right. Well, it ends up it's not a real concern, and I'll show you some of the data. This is an observational trial that was published from France a couple of years ago. They took severely preeclamptic women, all right, and gave them spinal anesthesia, and they compared them to a group of preterm women, so a control group approximately the same gestational age, and they were all undergoing cesarean delivery, and they all received spinal anesthesia. The primary outcome was blood pressure, all right, and incidence of hypotension. And then I'll point out to you that a subgroup of the preeclamptic women were also receiving magnesium. So we'll talk about that subgroup in a minute. So the primary outcome was the change in blood pressure. And I'm sorry, this is a little bit small, but what I want to point out to you is that there was no difference in the drop in blood pressure, systolic, diastolic, or mean, those are the three lines up there, between the preeclamptic group and the control group. All right, so everybody dropped their blood pressure. Some, okay, but there was no difference between the drop in blood pressure from baseline between the preeclamptic groups, some of whom were receiving magnesium, and the control group. So in the subgroup that were receiving either magnesium or nifedipine, again, if we look at the second line of the table, decrease in mean arterial pressure or the incidence of hypotension, we can see that after the induction of spinal anesthesia, there was no difference between the drop in blood pressure between the group that was receiving magnesium or nifedipine, or both, all right, and the untreated group. All right, so these were preeclamptic patients who had not received either magnesium or nifedipine. The fall in blood pressure was no different between these two groups. So again, I think this is pretty good evidence that we don't have to be concerned that women on magnesium who we are inducing spinal anesthesia on are going to have an abnormal or a different fall in blood pressure than women who are not receiving magnesium. All right, slight change in topic here. I'm not sure you've heard, but there's been a number of trials out there in non-pregnant patients looking at whether magnesium given intraoperatively improves postoperative analgesia. So there's been trials in abdominal surgery, in orthopedic surgery in particular, non-obstetric patients, so men and women in this case, are being randomized to magnesium or control group intraoperatively. One of my colleagues, or a group of my colleagues, recently did a meta-analysis of all of these trials, again, non-obstetric patients. The primary outcome in the meta-analysis was pain on movement or at rest, and they converted everything to a 0 to 10 scale that we're all used to dealing with, and they also looked at opioid consumption. So you can see here there's quite a number of studies in the meta-analysis, all right, and if you look at the bottom here, you can see that the triangle, the total triangle is to the left of the 0 line, which means that there's no difference in pain scores between the two groups. Actually, the overall point estimate of the difference in pain scores this is postoperative pain scores in patients who got magnesium intraoperatively compared to no magnesium was negative 0.74. All right, the 95% confidence interval was as much as 1.08 to as little as 0.48. Remember, this is a 0 to 10 scale. So you could argue with me, and it would be a valid argument, that a difference of negative 0.74 is not a big difference. In fact, other studies have shown that you need a difference of at least 1.2 or 1.3 in the pain scores to be a clinically significant difference. But it does appear that all of these studies, there is a difference in pain scores, although a very small one. All right. So we asked ourselves a couple of years ago whether in our patients who got magnesium for any indication, whether they behaved differently when we gave them combined spinal epidural analgesia. So this is a study that was headed up by John Sullivan in our institution. It was an observational study in which we compared laboring women who were preeclamptic and getting magnesium to women who were not getting magnesium. We did an intrathecal dose of 25 mics of fentanyl in all of these patients, and our primary outcome was the duration of analgesia, and there was essentially no difference. This is the Kaplan-Meier survival curve of the time or the duration of fentanyl. In other words, from the intrathecal injection until they first asked for a bolus of epidural local anesthetic, and it was not different between the two groups. So it doesn't appear, at least in this very preliminary study, that the patients who get magnesium on our units are behaving any differently from a labor analgesic standpoint than patients who aren't getting magnesium. These are just graphs of the magnesium concentration. The top graph is CSF magnesium, and the bottom graph is serum magnesium. On the, sorry, I can't get my pointer in the right space, but the y-axis is the duration of analgesia, and you can see there's no relationship there. Okay, so there's no relationship between the serum magnesium level and the duration of intrathecal fentanyl analgesia. All right, so what have we learned this morning? There are several indications for magnesium therapy in our obstetric patients. A new one, or relatively new one, is prophylaxis against the development of cerebral palsy in mothers at risk for preterm delivery. A more standard indication, which I think we're all aware of, is prevention of eclampsia in women who have severe preeclampsia, and it is also used to treat eclampsia. There are some interactions with things that we as anesthesia providers do that we all need to be aware of. One of the most dramatic is potentiation of our neuromuscular blockade. There has been concern that it causes or increases the risk of postpartum hemorrhage, but this does not appear to be the case based on current evidence. And it appears to be safe to administer calcium channel blockers and spinal anesthesia in women who are receiving magnesium without risk of catastrophic hypotension or circulatory collapse. So thanks very much for your attention this morning.